We're here at the Lugano meetings in Switzerland, and I'm here to discuss some of the highlights of the Aggressive Lymphoma education session. We had 3 presentations, one from Dr. Campo from Barcelona, and we had Ricardo Dalla Favera from New York, and myself from the University of Chicago. The topic was aggressive lymphomas, and we started with Dr. Campo, who discussed some of the WHO updates. As you know, the WHO is the premier authority in terms of how a diagnosis of lymphoma is made. And the WHO was last fully updated in 2008, and in 2016 there was a preliminary publication discussing some of the most important changes. Dr. Campo highlighted those changes, particularly as they affect early lesions as well as aggressive lymphomas. In terms of early lesions, the WHO has now identified that there are several entities, follicular lymphoma in situ and mantle cell lymphoma in situ, that may have a much lesser malignant potential, and therefore it is important to avoid overtreatment. He then turned to the new distinctions for aggressive lymphomas, whereby morphology still remains very important. So in other words, the pathologist still has to look at the material and make a determination regarding the aggressive nature, whether it is more centroblastic, immunoblastic, more aggressive like Burkitt, or more like a diffuse large B-cell lymphoma. However, the prior category that was called B-cell lymphoma unclassifiable no longer exists, and instead, once the morphology is determined, the diagnosis is finalized based on chromosomal changes and immunohistochemistry. So those high-grade lymphomas that have either a BCL2 or a MYC rearrangement are now called high-grade B-cell lymphoma with these rearrangements, or high-grade B-cell lymphoma without those rearrangements. This elimination of this category BCLU, the B-cell lymphoma unclassifiable, and the incorporation of the cytogenetics, I think, is a very important advance. Dr. Ricardo Dalla Favera then went into the biology of aggressive lymphomas, and he focused on several different aspects, but one key part of his talk was to discuss the differences between activated B-cell and germinal center-derived aggressive lymphomas. He went through some of the different pathogenic mechanisms and what is the same between those two subtypes and what is different. And I think what's very important is that the biology, our understanding of the biology has been improving, and as we know what pathways are relevant in each subtype, we can start to target them with newer agents. My topic was to discuss management, so clinical therapy and treatment for these patients with aggressive lymphoma. And within the aggressive lymphomas, the history of diffuse large B-cell lymphoma, which is historically the most common worldwide lymphoma that we see, has been CHOP and then R-CHOP. So for 15 years, R-CHOP has been the standard of care. And as we all know, although it's a wonderful therapy, there are some people, some populations that are not well served. This would include patients who have double hit lymphomas, increased protein expression of MYC and BCL2, which is now considered an adverse prognostic feature, older patients, those patients who have a high IPI, and patients who have the non-germinal center or activated B-cell type of diffuse large B-cell lymphoma. In the past year, there have been several very large trials that have been anticipated that showed their preliminary results. These were all trials that were trying to improve upon R-CHOP as the standard of care. And so we discussed the CALGB 50303. This was a randomized phase 3 trial conducted in the United States for patients with diffuse large B-cell lymphoma, and they were randomized to either dose-adjusted EPOCH-R or to R-CHOP. And despite this being a very well-designed study, multiple centers participated, in the end there was no difference between the two arms. The second study we discussed was the Goya trial. This was also a very well-designed study, 1,400 patients accrued from around the world, and patients were randomized between rituximab and CHOP or obinutuzumab and CHOP. And with 29 months of follow-up, the event-free survival and overall survival is identical. And there was no impact of the cell of origin in a sub-analysis that was presented at ASH prior to this meeting. The third group of studies that I discussed were those studies that tried to add treatment at the end of the R-CHOP, trying to take care of people who have early relapse. And again, these trials, including the Prelude study, the Pillar study, were negative studies. They also did not improve outcome. There is one trial, the Remark study, which used lenalidomide at the end of R-CHOP, and this is promising, but we await further data. So a big part of our discussion is, if we know these subsets exist, we know these high-risk groups exist, why is it that we can't power a study for these high-risk subgroups and then do a trial in that group? Because I do think that the reason these trials were negative is that it included a mixture of patients. Probably included some high risk, some low risk, and patients with very different biology. So unfortunately, I think where we are right now in this field is that even if we power our studies for these high-risk subgroups, there are so many barriers to getting patients onto a clinical trial that the sickest people, even within a category, are never included. And so although you design a study for a high-risk population, you really get the best of that one group. And so it is much more challenging to identify a difference with any kind of treatment. So we are left today, in 2017, with R-CHOP still as the standard of care for the majority of aggressive lymphomas, diffuse large B-cell lymphoma, and high-grade B-cell lymphomas without rearrangements. And the cell of origin, which has been around for 15 years, still has not impacted how we treat patients. The one exception to R-CHOP, and this is important, is that if a patient has double-hit lymphoma, where they have a rearrangement of MYC and BCL2, there we know R-CHOP is just so terrible that, or so ineffective, I should say, that augmented regimens are worthwhile. There are a number of augmented regimens, including dose-adjusted EPOCH-R, hyper-CVAD with rituximab, and Burkitt-like regimens such as Codax-IVAC, and these are all appropriate alternatives to R-CHOP for a patient with double-hit lymphoma. So that was the highlight of the session. It was a wonderful combination of pathology, biology, and then treatment, and thank you very much.